You check your blood sugar every morning, and the number stares back at you like an accusation. You are taking your prescription without missing a day. You have cut out the bread, the rice, the sweets that used to be a comfort. You are walking after dinner, even when your legs feel heavy. And yet, the number refuses to cooperate the way everyone promised it would when you started doing all the right things. There is a reason for that, and it is not a failure of effort or willpower. It is something happening inside your body at a cellular level that most medical appointments never address clearly, and most diabetes management plans completely overlook. Three minerals that your body absolutely depends on to process blood sugar are being silently depleted every single day by the disease itself. And today, I am going to walk you through exactly which minerals they are, precisely why your body keeps losing them, and the specific everyday foods that can begin restoring them starting this week. My name is Dr. Lena, and I have spent years in clinical practice focused on preventive and lifestyle medicine. One of the most striking patterns I have observed across hundreds of patients managing type 2 diabetes is that the people who are struggling most are often also the people trying hardest. They are not cutting corners. They are not ignoring advice. Something physiological is working against them beneath the surface of what standard diabetes management typically addresses. And once they understand what it is, things begin to shift. To understand why these minerals matter so deeply, you first need to understand something about what elevated blood sugar actually does to your kidneys day after day. When glucose builds up in the bloodstream above normal levels, your kidneys step in as a kind of emergency overflow valve. They filter the excess glucose out of the blood and excrete it through urine, which is your body's attempt to protect itself from the toxic effects of sustained high blood sugar. This is the mechanism behind a common diabetes symptom, frequent urination, and it sounds straightforward enough until you understand the hidden cost. When your kidneys push glucose out through urine, they do not do it cleanly. They pull minerals along with it, vital minerals. The same minerals your cells need to respond to insulin, your nerves need to function without pain, and your pancreas needs to produce and release insulin efficiently in the first place. And because blood sugar in type 2 diabetes is elevated not once or occasionally, but persistently and repeatedly across days, weeks, months, and years, this mineral drainage is not a temporary inconvenience. It is a continuous, cumulative depletion that compounds over time and quietly undermines every effort you are making to get your numbers down. Here are the three minerals at the center of this process. The first is magnesium, and its connection to blood sugar control is more direct and more consequential than almost anything you will hear in a standard diabetes appointment. Magnesium is lost through the kidney flushing process every time blood glucose rises above normal, which in type 2 diabetes means it is being excreted chronically, consistently, and in amounts that accumulate into serious depletion over months and years. The reason this matters so intensely for glucose control comes down to how insulin actually works at the cellular level. When insulin travels through the bloodstream and reaches a muscle cell, it attaches to a receptor on that cell's surface, which triggers a sequence of internal signals that cause the cell to open up and absorb glucose from the blood. Every step of that internal signaling sequence requires magnesium to function. Magnesium is not optional at this stage. It is structurally required. When your body is low on magnesium, those intracellular signals fire weakly or incompletely. The cell absorbs less glucose per insulin signal than it should, and blood sugar stays elevated. This is a form of insulin resistance that is driven not by diet alone, but by a mineral deficiency that the disease itself has created. The feedback loop this produces is exactly as damaging as it sounds. High blood sugar drives magnesium loss through the kidneys. Low magnesium impairs insulin signaling inside the cells. Impaired insulin signaling keeps blood sugar elevated. Elevated blood sugar drives further magnesium loss. This cycle runs quietly in the background of every day you are managing diabetes, and the glucose meter reading every morning is partly a reflection of where you are inside it. Beyond blood sugar, magnesium is the mineral that powers ATP production, which is the fundamental energy currency of every cell in your body. Heart cells, muscle cells, brain cells, all of them run on ATP, and all of them need magnesium to produce it efficiently. This is the direct cellular explanation for the exhaustion that so many people with diabetes experience even when they are sleeping adequately and eating carefully. It is not simply the burden of managing a chronic illness emotionally. It is a physical energy production problem at the mitochondrial level, and magnesium depletion is a primary driver of it. The nerve symptoms that are often attributed entirely to diabetic neuropathy, the cramping in the calves during the night, the restless sensation in the legs, the tingling that moves through the feet and toes, the difficulty falling or staying asleep, and the low-level anxiety that appears without clear external cause, all of these have a significant magnesium component. Magnesium is the mineral that regulates nerve excitability. It works as a natural buffer that keeps nerves from firing too readily or too intensely. When magnesium is depleted, nerves become hyperactive, and the result is precisely those symptoms that most patients assume are simply unavoidable features of living with diabetes long-term. They are not always inevitable. In many cases, they are expressions of a mineral deficiency that is addressable. The highest magnesium foods that are also compatible with blood sugar management are cooked dark leafy greens, and among these, cooked spinach is the most practical and most potent. 1 cup of cooked spinach delivers close to 40% of your daily magnesium requirement, and cooking is important here because it breaks down the plant cell walls that trap magnesium in raw spinach and makes the mineral bioavailable in a way that raw leaves cannot match. Add a small amount of olive oil or another healthy fat when eating cooked greens because magnesium absorption is supported by fat-soluble cofactors that need dietary fat present to enter the body properly. Pumpkin seeds are the other essential magnesium food, with approximately 1 ounce providing close to 37% of your daily need. They are one of the most convenient high magnesium foods available because they require no preparation and can be added to any meal or eaten as a snack without meaningfully affecting blood sugar. Almonds, avocado, and dark chocolate above 70% cacao are additional meaningful sources in portions that remain appropriate for glucose management. If supplementation is something you and your physician decide is appropriate, the form of magnesium matters enormously. Magnesium oxide is the cheapest and most common form in pharmacies, and is also the form that absorbs most poorly and is most likely to cause the digestive discomfort that leads people to stop taking it. Magnesium glycinate is the form with the best absorption, the gentlest effect on digestion, and the most consistent clinical performance. 200 milligrams per day, taken with a meal, is a reasonable starting point, adjusted gradually based on your response. 2 lifestyle factors beyond diet that accelerate magnesium depletion significantly are high sugar consumption, which triggers the same kidney excretion pathway as elevated blood glucose, and regular alcohol intake, which directly impairs the kidney's ability to retain magnesium, even in the absence of other risk factors. If either is present, the depletion is happening faster than the disease alone would cause. I want to share the experience of a patient I will call Margaret, 68 years old, 12 years into a type 2 diabetes diagnosis, on 2 oral medications, and arriving at my clinic with fasting glucose readings that had been stuck between 132 and 148 for over a year, despite what she described as strict dietary effort and daily walks. When I asked her about symptoms beyond glucose, she described night cramps that were waking her 2 or 3 times a week, fatigue that she had accepted as part of aging, and tingling in her feet that had been labeled peripheral neuropathy. Her blood magnesium was at the absolute lower boundary of the reference range, and I want to be precise about what that means because it is often misunderstood. Blood magnesium levels are maintained by the body as a priority, meaning the body will pull magnesium from muscle and bone to keep blood levels in the normal range for as long as possible. A blood level at the bottom of normal does not mean the body has plenty of magnesium. It means the reserves are depleted enough that blood levels are just barely being maintained. Total body magnesium stores were almost certainly significantly low. Margaret added cooked spinach with olive oil to 1 daily meal, began eating a small handful of pumpkin seeds each afternoon, and started magnesium glycinate at 200 milligrams with dinner. Within 3 weeks, the nighttime cramping had nearly disappeared. Within 6 weeks, her fasting glucose readings had shifted to a consistent range between 115 and 124. At her 3-month follow-up, her physician initiated a reduction in one of her medications. The food changed, the mineral environment inside her cells changed, and the glucose number reflected that change. The second mineral is zinc, and its role in diabetes is distinct from magnesium in a way that makes its depletion uniquely damaging. Zinc is lost through the same urinary mechanism as magnesium, flushed out through the kidneys alongside excess glucose on a continuous basis. But zinc has a specific structural role inside the pancreas that makes its depletion strike at the very source of insulin production. Inside the beta cells of the pancreas, insulin is not simply manufactured and immediately released. It is produced and then stored in microscopic granules within the cell, held in a precise crystalline structure while it waits to be secreted in response to rising blood sugar. That crystalline storage structure requires zinc to form correctly and maintain its integrity. Zinc is not incidental to this process. It is architecturally necessary. When zinc is depleted, insulin cannot be stored as efficiently, and it cannot be released as precisely or as effectively when the signal arrives. In a person with type 2 diabetes, whose pancreatic beta cells are already under considerable stress, adding zinc depletion to that environment means the pancreas is being asked to manage an already difficult job with one of its essential structural materials missing. The cellular machinery is compromised at the source. Zinc also plays a separate and important role at the muscle cell level, where it participates in the downstream insulin signaling pathway through a different molecular mechanism than magnesium, but toward the same outcome: more efficient glucose uptake into muscle tissue. When both zinc and magnesium are depleted simultaneously, which is the typical state in someone who has had type 2 diabetes for several years, the insulin signaling pathway is being disrupted at multiple sequential points at the same time. The dysfunction is not additive. It is multiplicative because each failure compounds the effect of the others. Zinc is also a foundational component of the antioxidant enzyme superoxide dismutase, one of the body's most important defenses against the oxidative damage produced by chronic high blood sugar. When zinc is insufficient, this enzymatic defense is weakened, and the oxidative stress that accelerates diabetic complications in the peripheral nerves, the kidneys, and the small blood vessels of the eyes progresses more rapidly. This is a direct mechanism through which zinc deficiency contributes to the pace of neuropathy, nephropathy, and retinopathy in people with diabetes. The signs of zinc deficiency become recognizable once you know what pattern they form. Wounds that heal more slowly than expected are among the most diagnostically useful. Zinc is required at every phase of tissue repair. A cut or abrasion on the foot that is still open 2 weeks later is not just slow healing. It may be zinc deficiency interrupting a biological repair process that your body is actively attempting to complete. Increased susceptibility to infections and colds, catching respiratory illnesses more easily and taking longer to recover, reflects zinc's critical role in immune function, particularly in the natural killer cells that constitute the body's first line of response to viruses and bacteria. Zinc deficiency impairs these frontline immune cells meaningfully. Persistent and intense sugar cravings, unexplained gradual hair thinning, chronically dry or slow-healing skin, and a diminished sense of taste or smell are additional indicators that zinc status may have declined significantly. The most bioavailable zinc sources are animal-based. Oysters are the single most concentrated zinc food known, with 3 medium oysters providing well over double the daily requirement. Grass-fed beef provides approximately 40% of daily zinc needs per 3-ounce serving, and beef liver delivers even more per equivalent portion. For those who prefer or rely primarily on plant-based sources, pumpkin seeds are again the most practical option, providing approximately 50% of daily zinc needs per ounce and making them one of the most strategically valuable single foods for someone managing diabetes, addressing both magnesium and zinc deficiency simultaneously in a food that has minimal impact on blood glucose. Chickpeas and lentils contain zinc, but also contain phytic acid, a compound in the plant cell wall that binds to zinc and significantly reduces its absorption. Soaking legumes overnight before cooking, or allowing them to sprout, breaks down phytic acid substantially and meaningfully improves how much zinc the body can actually extract from the food. This preparation step is not optional if legumes are a primary zinc source. Zinc picolinate and zinc bisglycinate are the supplemental forms with the best absorption and the fewest gastrointestinal side effects. A range of 15 to 25 milligrams of elemental zinc per day is typically appropriate for people with diabetes. One important caution applies at sustained doses above 40 milligrams. Zinc begins competing with copper for intestinal absorption and can gradually deplete copper stores over time. If supplementing above 15 milligrams daily for extended periods, including 1 to 2 milligrams of copper alongside it, maintains the essential balance between these two minerals. The third mineral is chromium, and it is the least recognized of the three, despite operating at the most fundamental level of insulin function, the receptor itself. Over decades of nutritional and endocrinological research, scientists identified a biological compound that has a profound effect on how efficiently insulin binds to its receptor on the cell surface. This compound, identified in early research as the glucose tolerance factor, has chromium as its essential and active mineral component. To understand why this matters practically, consider what has to happen every time insulin tries to deliver glucose to a muscle cell. Insulin travels through the bloodstream, reaches the cell, and extends toward the receptor molecule embedded in the cell membrane. For that binding to occur with full efficiency, for the insulin signal to be transmitted into the cell with the strength and clarity needed to activate glucose uptake, the receptor has to be in an optimal state of responsiveness. Chromium is the mineral that helps maintain that receptor in its most responsive configuration. When chromium is depleted, insulin binds to the receptor less completely and less efficiently. The signal that enters the cell is weaker. Less glucose is absorbed per unit of insulin than the available insulin should theoretically be producing. Blood sugar stays higher than it should, even when insulin is being secreted in normal or elevated amounts. This is not the same mechanism as magnesium deficiency, which impairs the intracellular signaling that happens after insulin has already bound to the receptor. Chromium deficiency impairs the binding event itself. These are failures at two consecutive steps in the same biological sequence, and in many people with type 2 diabetes, both failures are operating simultaneously. Chromium is depleted through the same urinary pathway as magnesium and zinc when blood glucose is chronically elevated. But there is a second depletion mechanism for chromium that is particularly significant for people over 55 who are managing a long-term chronic condition. Cortisol, the primary stress hormone, directly increases urinary chromium excretion. Cortisol rises with psychological stress, with insufficient or poor quality sleep, with physical illness, and with the sustained emotional weight of managing a condition that requires constant attention and daily decisions. This means that the stress inherent in living with diabetes is actively accelerating the chromium depletion that the disease itself is already causing through elevated glucose. The people who are most stressed and most sleep-deprived are losing chromium fastest, which makes insulin binding less efficient, which makes blood sugar harder to control, which generates more stress. The symptoms of chromium depletion overlap significantly with the general picture of poorly managed diabetes, blood sugar that remains stubbornly difficult to control despite genuine and consistent effort, intense and specific cravings for carbohydrates and sweets, mental fatigue and difficulty with focus and clarity, and mood instability that seems disproportionate to external circumstances. These are not simply features of having diabetes. They are signals that chromium depletion may be amplifying the underlying insulin resistance in a way that neither medication adjustments nor dietary management alone can fully compensate for. Broccoli is the most practically accessible and most consistently chromium-rich food available, with half a cup of cooked broccoli providing approximately 50% of the daily chromium requirement. It is also simultaneously an excellent source of dietary fiber, vitamin C, and sulforaphane, a phytochemical with well-documented anti-inflammatory properties that are particularly relevant to the inflammatory environment of chronic elevated blood sugar. Making broccoli a feature of 2 meals per week is one of the most cost-effective and nutritionally efficient single changes a person with diabetes can make. Lean beef provides approximately 25% of daily chromium needs per 3-ounce serving. Eggs contribute 10 to 15% per large egg. Brazil nuts are among the most chromium-dense plant foods, with a single nut delivering close to 30% of the daily requirement, making them a small but highly efficient addition to the diet. For supplementation, chromium picolinate and chromium polynicotinate are the two forms with the strongest clinical evidence specifically for blood sugar benefit. The effective dosage range supported by research is 200 to 500 micrograms per day. Starting at 200 micrograms and evaluating over 6 to 8 weeks before considering any adjustment is the appropriate approach. Chromium's effects on insulin sensitivity develop gradually. The research consistently shows that meaningful changes in fasting glucose and insulin receptor function emerge over 8 to 12 weeks of consistent supplementation, not days or even 2 or 3 weeks. Patience with the timeline is necessary for an accurate assessment of whether it is working. The habits that deplete chromium most aggressively beyond what the disease alone produces are high refined carbohydrate and sugar intake, which increases insulin demand and simultaneously drives increased chromium excretion through the kidneys, consistently poor or insufficient sleep, which keeps cortisol chronically elevated and its chromium depleting effect active, and regular alcohol consumption, which disrupts chromium metabolism through mechanisms independent of its other effects on blood sugar regulation. Now consider the complete picture of how these three minerals interact within a single biological process. Chromium supports the efficiency with which insulin binds to its receptor on the cell surface. Magnesium enables the intracellular signaling cascade that is triggered by that binding and that ultimately activates glucose uptake. Zinc is required for insulin to be stored correctly in the pancreas, released precisely at the right moment, and for the downstream molecular events inside the cell that bring glucose transporters to the membrane where they can do their job. These are three separate functions at three sequential stages of the same insulin-glucose management process. When one is compromised, the whole chain works less effectively. When all three are compromised simultaneously, which is the common reality for someone who has been living with type 2 diabetes for several years, the cumulative functional impairment across the entire pathway is substantial and measurable in the morning glucose reading that greets you every day. This is the underlying reason why managing blood sugar with medication and diet, while leaving these mineral deficiencies unaddressed, produces results that feel incomplete, because they are incomplete. The system responsible for insulin signaling and glucose metabolism is running with multiple components operating below the threshold they need to function properly. Addressing glucose as a number without addressing the mineral environment in which insulin is trying to do its job is like trying to improve the output of an engine while several of its essential components are worn down. Here is what to begin this week. Add cooked spinach prepared with a small amount of olive oil to one meal each day. This addresses magnesium in its most bioavailable dietary form, with a change that is simple, affordable, and sustainable. Add a small handful of pumpkin seeds daily, either as a standalone snack or mixed into a meal. 1 ounce addresses both magnesium and zinc at the same time, with essentially no glycemic impact, making this one of the highest value single additions to a diabetic diet. Add broccoli to 2 meals this week, half a cup cooked at each, which begins meaningfully addressing chromium in a form that also contributes fiber, anti-inflammatory compounds, and vitamins relevant to metabolic health. Before beginning any supplement regimen, discuss it with your physician, especially if you have kidney disease, cardiovascular conditions, or are on medications for blood pressure, glucose, or cardiac rhythm. If supplementation is appropriate for your situation, the forms to prioritize are magnesium glycinate, zinc picolinate or bisglycinate, and chromium picolinate, as these are the forms with the best absorption profiles and the most consistent clinical evidence. Reduce the habits that are accelerating depletion beyond what the disease alone is causing. High sugar intake, alcohol consumption, and chronic poor sleep all amplify the mineral losses that are already occurring. Addressing even one of these meaningfully reduces the rate at which your body is being depleted of what it needs to respond to insulin properly. Give these changes adequate time and evaluate honestly. Magnesium improvements in sleep quality, cramping, and nerve symptoms typically become noticeable within 2 to 4 weeks. Changes in fasting glucose readings generally become visible at 4 to 8 weeks of consistent dietary attention. Chromium effects on insulin sensitivity and receptor function develop over 8 to 12 weeks. This is the timeline of real biological restoration, not a supplement promise. It is the pace at which your cells actually rebuild the mineral environment they need. The number you check every morning is not only a glucose reading, it is a window into whether your insulin receptors are capable of binding and responding properly, whether your pancreas has the structural materials it needs to store and release insulin efficiently, and whether the mineral infrastructure that the entire insulin signaling process depends on is present and adequate. For many people with type 2 diabetes, that infrastructure has been quietly eroded for years, and no one has pointed to it clearly. Now you understand what has been happening and what can begin to change it. The medication is contributing what medication can contribute. The dietary effort is contributing what diet can contribute. These three minerals address the layer that neither medication nor diet alone can fully reach because it operates beneath both of them at the level of the cellular machinery itself. I am Dr. Lena. If this explanation filled in a gap that your clinical care has left open, share it with someone who is working hard at managing their diabetes and still cannot understand why the results are not matching the effort they are putting in. I will see you in the next one.